Hi, my name is Shanil Patwary. I am an exercise physiology student studying at Charles Stewart University. The following presentation is about my experience working with clinical populations and how I applied the scope of practice of an accredited exercise physiologist in clinical situations. Scope 2.1 is the screening and risk stratifying to ensure the safety and appropriateness of exercise and physical activity interventions. For this artifact, I have chosen the Nepean Hospital Initial Assessment Screening Questionnaire. Pre-screening and risk stratifying is a useful tool an exercise physiologist can use to determine their exercise status. The study performed by McHugh, Williams and Fell 2007 calls for further discussion and possible revision when administering an assessment, as patients may not know their condition very well, leading to false positives and improper risk stratification. This is further supported by Neto, Luz and Farinati's findings from 2013, suggesting applying a physical activity questionnaire on elderly people aged 69 and above would be inadequate. This can be due to the patient's education status, age and cognitive state. Most patients undergoing initial assessment for the exercise program at Nepean are already at a moderate to high risk, as they are outpatients 6 weeks post-cardiac surgery. The questionnaire design is quite simple and easy to write down any extra patient details, with the option of an interpreter for the patient. During the assessment, the EP or nurse would ask the patient yes or no questions regarding any other comorbidities and smoker status, and mark the appropriate responses on the sheet, paying particular interest to the patient's family history. Family history is a very important factor in risk assessment of a patient, especially for cardiovascular and stroke patients. Kulstrata et al. 2015 found that screening for family history for CVD and stroke patients allowed for early detection and management for the patient's modifiable risk factors. Scope 2.2 is assessing a person's movement capacity in people of all ages and status. For this, I have chosen the 6-minute walk test. It was standard procedure for patients to give their consent and participate in the test after their initial or final assessment. Prior to starting the test, the patients were equipped with a pulse oximeter which allowed to procure readings of their heart rate and oxygen saturation. The patients were also advised of the modified 1 to 10 Borg scale and were asked how hard they were working before the walk, 2 minutes into the walk, 4 minutes into the walk, immediately after the walk, and a few minutes post-walk. Patients walked a 30-meter course with the objective to cover as much ground as possible, i.e. as many laps as they can. The 6-minute walk test is a standard test that can be applied to any patient. Ingle, Cleland, Clark 2004 found that the distance traveled is an independent predictor for all-cause mortality, especially in heart failure patients. Wegrinovska-Teodorchik et al. 2013 found that heart failure patients unable to walk 468 meters within 6 minutes had a lower survival rate than those who did. Thus, the distance covered is an important value to determine a patient's functional capacity and cardiovascular risk stratification. Rate of perceived exertion is not always an accurate indicator of exercise intensity, as Amott, Fobord, Carlson and Stoylen 2014 suggests, as a patient may engage exercise at a lower intensity, i.e. not walk to their best ability. This is rectified through the use of the pulse oximeter or a heart rate monitor so the patient can work at a target heart rate. Scope 2.3 is the development of safe, effective, individualized exercise intervention. For this, I have chosen the exercises I prescribed to a patient, Claire, for a home program. Claire is a 58-year-old woman who had a myocardial infarction and a PCI. She also has a couple of other comorbidities such as depression and insulin resistance. She is undergoing a final assessment after completing her hospital exercise program. Her goal is to resume her former physical activities and be able to walk long distances without tiring. Things to consider are to avoid overhead movements and holding exercises for too long, such as planks, bridges, for example, which can alter and affect her blood pressure. Also, exercising at least 2 to 3 times a week with a 48-hour gap between training the same muscle groups as prescribed by the ACSM guidelines. The exercises chosen were similar to the exercise prescriptions in the Healthy Hearts program that she completed, in that it is a circuit with various options to play with. Claire was noted to have more functional capacity and exercise tolerance than others in her cohort, and had the option of performing floor exercises, i.e. bridging and bird dog. It is important for women such as Claire to adhere to an active lifestyle. The home program design is very similar to Woodward et al.'s 2015 prescription template. By having a clinician-approved exercise prescription with a goal written, it is hoped that Claire adheres to her exercise routine. Combining the interval training with the resistance exercises, i.e. dumbbells and therabands, this will help in reducing insulin resistance, as supported by Marquis-Garvel findings in 2015. Ramirez-Campillo et al. 2014 also supports the benefits of resistance exercise with evidence that resistance training improves functional capacity, muscle performance, and quality of life in older women, favoring high-speed programs for greater gains than low-speed exercise programs. Scope 2.4 refers to the provision of health education advice and support to enhance a patient's health and well-being. The artifact I have chosen is the Depression Fact Sheet handout. After the exercise session, the patients had the option to attend seminars led by nurses, EPs, and pharmacists to improve their knowledge of their condition. Depression was prevalent in a lot of the patients in the program. Krishnan et al. 2002 evaluated that depression is a comorbidity that intertwines with other medical conditions such as obesity and diabetes. The handout is a comprehensive guide about depression, how to detect it, how to manage the condition, and who to call when necessary. This guide is very important as DiMatteo, Lepper, and Crohan in 2000 observed that when untreated, patients with depression become non-compliant with medical treatments such as forgetting medication, not engaging in physical activity, and cancelling doctor's appointments, which can exacerbate their condition. The handout explains the benefits of exercise and maintaining a healthy, active lifestyle. This is supported by Blumenthal et al.'s findings in 1999, where adherence to exercise training induces a number of potential psychological benefits. For example, it improves cognitive function, improves mood, and improves an overall sense of well-being. Scope 2.5 is the provision of exercise intervention and advice for those at risk of developing a chronic condition or injury. I have chosen the Nepean Hospital Healthy Hearts program as my artifact. Cardiac outpatients 6 weeks post-operation were referred to the program by their GP or cardiologist. Patients engage in a 1-hour exercise session twice a week. The exercises consist of a circuit training alternating between upper and lower body exercises mixed with aerobic training, example treadmills and recumbent bikes. Each patient had a target heart rate to train in. The exercises were functional in nature and can be applied in any real-world settings, for example the sit-to-stand, walking up and down, and certain pulling exercises. The goal is to enhance each patient's functional capacity and endurance. A majority of patients had a non-exercise or physical activity background, so their response to the program yielded very positive results. Curry et al. 2014 found that fitness improved in CAD patients within the first 3 months of training when adhering to an exercise program. Exercise adherence is a very important factor in managing cardiovascular disease. Berendt et al. 2012 found a link between reduced functional capacity, quality of life, and independence in cardiac outpatients as a result of non-adherence to an exercise or a diet program. Lataris et al. 2013 found evidence of combining aerobic and resistance training to improve patients' overall health, which is why the Healthy Hearts program is very effective. The workload in the exercise sessions was set at 2 sets of 10 reps, with 30 seconds rest in between. As Berendt et al. Found in another study in 2011, that increasing the volume to 3 sets of 15 rather than keeping it at 2 sets of 12 in their study found that there was no significant increase in strength or functional capacity when in a cardiac rehabilitation setting. Scope 2.6 is the provision of clinical exercise prescription for those with complex medical conditions. For this, I have chosen my home exercise prescription for another patient, Vernon. Vernon is an 80-year-old man with 4 cabbages, stents, high blood pressure, aortic valve surgery, and is on medication for high blood pressure and he's on beta blockers. His goals are to improve his functional capacity, his exercise tolerance, and his independence for daily activities. Vernon really enjoyed the Healthy Hearts program, so his exercise prescription does not deviate too much from it. Exercise in all its forms provides so much benefit to the patient. Arena, Callan, Borgie-Silva, and Myers 2015 found that exercise training improved the aerobic capacity, the muscle strength, exercise tolerance, and quality of life for patients with pulmonary hypertension. It was also found to reduce pulmonary blood pressure, thanks to Greelin, Laughlin, O'Connor, and Dunker's findings in 2015. Brunning and Stewart 2015 can also add to the list of benefits of exercise, as their study showed exercise training increases myocardial oxygen demand and augments coronary blood flow. Scope 2.7 is a provision of rehabilitation for acute injury patients to restore functional capacity and well-being. For this artifact, I have chosen a patient from Ripple's Hydrotherapy, Dominic. Dominic is a 37-year-old male with an L5 disc prolapse and reporting lower back pain from a workplace injury, currently taking paracetamol and anti-inflammatories to minimize his lower back pain. His goals are to improve his functional strength, his exercise tolerance, and to return to work. Things to consider are his exercise prescription should focus on muscular endurance, so high repetition, avoid heavy loads which may exacerbate his condition, and focus on the technique to ensure he's doing the exercise correctly and avoiding any sort of unwanted muscle compensation. Dominic's program is a combination of resistance training and aerobic training. The resistance training utilizes the core in a majority of the movements for stability purposes. The use of a Swiss ball to encourage lumbar multifidus activity is an effective method for spinal rehabilitation, as concluded by Scott, Vaughan, and Hall 2015. Despite being primarily a lower body injury, there is emphasis on upper limb exercises. D'Souza, Castella, Oliveira, and Goncalves 2009 stated that the presence of trunk and lower back muscle activation is beneficial, as they maintain the spinal position and correct posture during sustained upper limb exercise. The choice of pulling exercises such as a seated row and the lat pull down were observed thanks to McGill, Cannon, and Anderson's 2014 study of muscle activity and spinal load on pulling exercises and Dominic's functional capacity to perform them. Scope 2.8 refers to the locations of where I completed the other 7 scopes of practice. I completed these scopes during my placement at Nepean Hospital and Ripple's Hydrotherapy Center. The first placement was at Nepean Hospital, specifically the musculoskeletal and pulmonary gym. The gym program falls under the secondary level of care, where patients are first referred to by their GP or cardiologist to participate in. Patients are then assessed by the exercise physiologist before starting. During the program, the EP and nurses are present to assist with any patient needs and collect data such as blood glucose levels, blood pressure, and heart rate during exercise. The second placement was at Ripple's Hydrotherapy Center in St. Mary's. This facility has heated pools and a gym for patients to exercise in. Ripple's comes under secondary and tertiary level of care. Patients can be referred here by their GP or specialist doctor. People who have injuries through work can come here via work cover insurance. There is also the option for veterans to participate through help from the Department of Veteran Affairs. This concludes my presentation of my experience during work placement and my clinical portfolio. I have covered all scopes of practice of an exercise physiologist and applied them in real clinical situations. I also used an evidence-based approach to justify my reasoning for exercise prescription. Thank you for your time.